Is there any pain at rest, and where is it felt? The patient performs 4 active lumbar movements, and we ask him whether any of them bring on or alter his pain. As always, pain can be produced, worsened, or abolished. If the patient's pain increases, do not automatically assume that there is more pain at the same location as pain at rest. At the end of the flexion, we ask the patient to add a neck flexion as a complementary dural stretch. Beware that a painful arc on those movements is possible. Then we perform an S1, S2 motor test, unilateral rising on tiptoe. Followed by the sacroiliac distraction test. If central pain is produced, the test is negative. If unilateral gluteal pain is produced, we repeat the test in a more intense way with a lumbar support. If positive, the complementary sacroiliac examination is called for. From now on, we perform all tests bilaterally on the good side first. The straight leg raise test is done in a passive way, and we assess pain and range of movement. Then, neck flexion is added and its effect assessed. Don't stop at the first pain, since a painful arc can occur. Keep in mind some important details. A straight leg raise is not only a test for the L4, L5, S1, S2 nerve roots, but also for the durameter. So during a straight leg raise, we also put some strain on the durameter. So it's quite possible that a patient with a positive straight leg raise only has back pain and not necessarily leg pain. It's also possible that the left straight leg raise produces back pain on the right side. That's what we call a crossed straight leg raise. It's possible we produce a painful arc on straight leg raise. At the end of the straight leg raise, we can ask the patient to perform a supplementary neck flexion, and then the patient can state that he has more pain or even less pain. In both of those cases, this is a clear dural sign excluding facet involvement or sacroiliac involvement. I refer to the EDGOM publications and the international EDGOM courses for more practical details on that subject. Hip, passive flexion and rotations. For differential diagnostic purposes, we perform some hip tests, since the hip can refer pain in the lumbar area. It is also imperative to perform the hip flexion immediately after the straight leg raise. This will enable us to discover a sign of the buttock. Nerve root examination, resisted hip flexion, L2, L3. Resisted dorsiflexion foot, L4. Resisted dorsiflexion big toe, L4, L5. Resisted eversion, L5, S1. We look for sensory deficit in the distal part of the dermatomes. Distal part of anterior thigh, L2. Distal part of anterior leg, L3. Big toe, L4. Inner side of foot, toes 1 to 3, L5. Outer side of foot, toes 4, 5, S1. Plantar aspect of heel, S2. Knee jerk, L3. Babinski jerk. Ankle jerk, mainly S1, S2. We continue with the motor tests. Resisted knee flexion, S1, S2. Resisted knee extension, L3. Passive knee flexion, L3. This is a stretch of the L3 nerve root via the femoral nerve. We look for atrophy during a contraction of the gluteal muscles, S1, S2. And finally, we perform an extension pressure on the spinous processes. Execution. We apply the middle of the 5th metacarpal bone onto the spinous process. The hand is held almost flat, for comfort reasons, and reinforced with the other hand. Both arms are extended. Our slightly spread legs lean against the couch. We use part of our body weight to take up the slack, and with more body weight we provoke each segment. We assess pain and end feel. Normally it's elastic.